Thank you very much for the kind introduction. Also thanking for inviting me to give you the perspective of the International Agency for Research on Cancer, which is a cancer research agency of the World Health Organization. So we are part of the World Health Organization family, but I think we are the only research agency within the WHO family. So on one hand, we are operating according to the rules of the United Nations, but then on the other hand, we are more functioning actually like a university or any other research organization. So it's really my pleasure to introduce you to our activities. And we have the following research areas that are not directly probably health risk assessments, but they are also evidence synthesis and risk assessments that are, of course, because we are working exclusively on cancer, that they're all related to cancer prevention and how to protect people from carcinogens and how to teach you a healthy lifestyle that helps you to reduce the risk of developing cancer. So maybe the best-known program of the agency is the IARC monograph program on the identification of carcinogenic hazards to humans. And already in the first presentation today, this distinction between hazard identification and risk assessment was made. Because for the hazard identification, the underlying question is an agent carcinogenic or not? So it sounds like a yes or no question. In reality, unfortunately, very often the answer is maybe. But nevertheless, here we're not yet talking about the doses that would needed to cause cancer. What is the dose-response relationship? Under which exposure circumstances would you develop cancer? This program runs for 50 years, and more than 1,000 different agents have been evaluated over all these years. And there's the handbooks on cancer prevention that is looking at interventions to reduce the cancer risk. So for instance, there have been many handbooks on tobacco prevention, so seeing, for instance, and reporting the taxation policies are actually a very good way to reduce the amount of smokers in the population, which, by the way, smoking and tobacco is still causing half of all the preventable cancers in Europe, 70 years after we have very clearly, with the help of epidemiology, discovered that smoking causes cancer. So this directly leads to our activities on cancer prevention. There's the IARC recommendations on cancer prevention that we kind of have the umbrella project called the World Code Against Cancer Framework. And we have these codes, which are really recommendations to the individual how to reduce the risk of cancer for Europe, where the 4th edition of the code has been published in 2012. We are working on an update at the moment. And only a couple of weeks ago, we launched for the first time a code for the Latin America and the Caribbean. Just a quick question. Could you lift your hand, please, if you're familiar with the European Code Against Cancer? Okay, so this was my last slide, but it was nice to be here. No, okay, I ask the same question tomorrow again, huh? Okay, but also sometimes we have very targeted output where we do risk assessment for very specific questions. So for instance, what we have done as an exercise for the French government is calculating so-called attributable fractions. So looking at the different exposures where we know that they are causing cancers, what is really the cancer burden related to these exposures. And we estimate that actually around 45% of cancers in Europe could be preventable if everything that we know about the causes of cancer and the interventions that would help us to reduce these exposures, if this was put rigorously in place. But sometimes also very specific risk assessments, like that we developed some guidelines on thyroid screening after nuclear accidents. And what will be a recurring topic during my talk is that I really want to show the assessment of quality of studies and the critical appraisal of the results. That should not start at the level of doing the risk assessment. It may be too late. And we heard during many talks that it's difficult to get access to the raw data anyway. So the people that can make the best critical appraisal of the quality of the study are the people sitting on this raw data. But sometimes there needs to be the encouragement there needs to be the funding, and there needs to be the framework to do so. Because even if you develop the most fantastic instruments for assessment of a risk of bias, they cannot overcome if the underlying data that is evaluated has considerable flaws, and especially if these flaws are not clearly expressed in the publications. And I mean, who wants to publish something and saying, oh, by the way, there's this terrible study from Schüz et al. And they really messed it up. This is what you hardly find in the literature. And IARC is a place where we put a lot of work into this because we are there for facilitating international research. So we are leading some big international research consortia or also some big multinational studies. So first, back to the monographs. So cancer is really an epidemic on the rise, and the reason is the demographic changes. You may know that cancer is specifically affecting the more elderly populations. So the higher your age, the higher is your risk of cancer. And since the life expectancy is increasing in Europe, that means also the cancer burden is increasing. So worldwide at the moment, we have about 20 million new cancer patients per year. And this number will increase in the next 20 years to 30 million per year. And this is not a kind of a worst-case scenario. This is the most realistic projection that we can do right now. And this means why prevention is so important, because where should all these oncologists come from? Where should all these nurses come from to treat the patients? This is not just a question of the money. This is also a question of the human resources. And we also see a shift of carcinogenic exposures to low-middle-income countries where, like in the high-income countries already for the last 10, 15 years, obesity is on the rise. Unfortunately, we still have countries where the tobacco use is increasing instead of decreasing. Now we have this new hip lifestyle of vaping. And we can see that youngsters who start vaping more often become conventional smokers later on. So it's another devilish plot of the tobacco industry to really trick our young people into the good old but very harmful habit of smoking. So the first step in cancer prevention is to identify the causes of human cancer, and this is what the IARC monographs is doing. And this is a kind of a dual role. I can read it, okay? Because it's an evaluation of the latest scientific research, making a classification. But if the classification is not clear, so if we are not coming with this, yes, there's convincing evidence that an agent is carcinogenic, it can also stimulate further research. And we have seen this particularly for the question of night shift work and the risk of breast cancer that was evaluated for the first time in 2007. And it really initiated a series of new research looking into this question. Because of the large number of people working at night shift, it would really be a large breast cancer burden if this was a true causal association. So night shift work has been recently re-evaluated, and it ended up in the same maybe category, unfortunately. So unfortunately, as an epidemiologist, you need a lot of patience, and sometimes, even when you do your best, you don't get a clear answer. So still something for young people here who want to become epidemiologists and win a Nobel Prize. There's still a lot of opportunities. So what happens during this IARC evaluation? It's the similar steps as in the health risk assessment. You identify the relevant information, you collect all the relevant studies, you evaluate the study quality, and then it's the 3 lines of evidence that are evaluated separately: the cancer in humans, which for cancer-causing agents is usually observational epidemiological studies, and they are categorized the evidence into sufficient evidence, limited evidence, or inadequate evidence. The same is done with the animal studies, and the same is done with the cell experiments or other mechanistic data that is useful to decide whether there's strong evidence that the mechanism that is known would also apply to the exposure-outcome relationship in humans or not. And at the end, the overall evaluation groups these agents into the so-called group 1, which means the agent is carcinogenic to humans, then the maybe category is split into two subcategories. If the evidence is a little bit stronger, so this is an evaluation of the strength of the evidence, it's not an evaluation of the strength of association, then it's the group 2A, probably carcinogenic to humans, the group 2B, the evidence is weaker, this is possibly carcinogenic to humans, possibly carcinogenic. This is really the class that one would say further research is needed to get a clearer answer. And group 3 is not classifiable as to its carcinogenicity to humans. You wonder why there's no group 4. This group 4 of not carcinogenic has been abolished because over all these 50 years, only one poor chemical ended up in this category. And this is the way that science is also built up. To prove the non-existence of an association is virtually impossible with research. So when you have the classification of the 3 lines of evidence, then it's a relatively simple matrix for the overall evaluation. So if there's sufficient evidence for cancer in humans, then it ends up automatically in this carcinogenic group 1. So you see that in the IARC monographs, the epidemiology is one of the key disciplines that is determining really the outcome of the classification. The only exception is if there's sufficient evidence in animals and a really strong mechanistic evidence that this mechanism would act in exposed humans, then you can also end up in the carcinogenic class group 1, no matter how the evidence of cancer in humans was classified. When the human evidence is limited, then most likely you end up in one of these categories of probably or possibly carcinogenic, also depending on what the animal and mechanistic studies say. And not classifiable really means there's no evidence from the epidemiological studies. So even when the animal study can be sufficient and the mechanistic data says there's no mechanism known how this would act in humans, there's no evidence from the epidemiology, you can still end up in group 3. So the evaluation of the individual epidemiological studies and the monographs is not following, not using a risk of bias instrument, but the individual studies have been evaluated also individually. So in the monographs, there's always a small description of what the evaluator think, what are the weaknesses of the different studies, even if sometimes not reported by the authors themselves. But we have also seen in the monographs group that there's probably a need for having a more systematic approach also for the communication of how the classification was made. And there has been a workshop between IARC and the NCI from the United States to develop such a toolkit to make it more transparent of how the evaluation of the individual studies is being done. So for the World Code Against Cancer framework, the approach is a little bit different because here we want to give only recommendations when we have a guarantee that following the recommendation would reduce your risk of cancer. So this Code Against Cancer program is not a program that takes precautionary measures or something like this into account. It's really saying, okay, we give you this recommendation, for instance, do not use sunbeds, because we know, and it's scientifically established, that if you use sunbeds regularly, it gives you a higher risk of developing melanoma of the skin. And this has been well described. The mechanism is clear. We know that one session of sunbed use per week increases your risk by 2%, and we can estimate even what the population risk would be, because from surveys we know how many people regularly use sunbeds. So the mechanism here is that we also look at the scientific evidence. So here the scientific evidence has to be very clear. We are using the authoritative sources like the IARC monographs or the handbooks, the screening guidelines by the European Commission, for instance, as a source, so that we don't have to repeat all the systematic reviews from scratch. For nutrition, because many dietary factors are not evaluated by the IARC monographs program, there's the World Cancer Research Fund continuous update program. that follows a similar mechanism like the IARC monographs, but for dietary habits. So we use them as the authoritative source for the nutritional factors. And then for the code, there's another decision criteria because we only make a recommendation if this is really an agent that is important that the entire general population is aware of. So there has to be a critical mass of exposed in the general population. If it's a factor that is easier reached by a targeted prevention, for instance, a specific occupational chemical that does not appear in the natural environment, but really only in a certain occupational process, it would not become part of the code, because here we would say a prevention approach targeted specifically at these industries would be more successful. And another criterion is whether the message can be delivered to the people in a very clear way. And this is something that actually gets a little bit of also probably focus later today. So X-ray medical diagnostic procedures is an example here, because we know that this is ionizing radiation. So in principle, it is a carcinogen. But of course, doing a computer tomography examination is to the benefit of the patient. So here it's not the individual that should make this risk-benefit analysis, what is good for me. This has to be a decision made with the respective medical expertise. So this is why we would not put it in a code. And why I say this gets a focus today, that because in 1 hour roughly, we come out with results of a big study showing actually that computed tomography examinations during childhood increase your risk of developing leukemia later in life. And this will be one of the results, probably difficult to communicate, because we also don't want that people tell the doctor, oh no, I don't want a CT examination. But the radiologists have to be aware that unnecessary examinations or dose adjustment for children is very important. So these are the two main risk assessments that we are doing at the agency. But I'm coming back to this point that the critical evaluation of bias is important at the study level, because this is really the only place where the quality can be checked. Because the synthesis of studies in a risk assessment is, of course, key to derive conclusive results, just because of the increased sample size you have for making your decisions. And there are good methods, as we have seen, to assess the study quality, if it's possible to assess the study quality. But assessing the study quality can be very challenging if the original study is not making an effort to identify the limitations in their study themselves. And I mean, there are many reasons why sometimes this is not so clear. I mean, there's journals who pay a lot of attention, that, of course, this critical appraisal is part of the original paper. We know that there's more and more journals who probably are more interested in collecting the open access fees, but not so interested in following a very strict peer review process. There's, of course, the word count of the journal that sometimes people have to balance what they put into the original report or not. And I mean, a bias evaluation in the individual study is most often also only possible if you collect additional data that allows you to do this bias assessment. In too many papers, I read a sentence saying like, oh, we didn't find any evidence for selection bias. But then you're reading the paper and you say, well, you did not really check for selection bias. So that's maybe an explanation where you didn't find any evidence. But of course, when you don't have any additional data, how you can evaluate whether there's a risk for selection bias, how do you do this? So I think we all, as epidemiologists, and maybe with the support of the risk assessors, have to work on, first, that epidemiologists get the time, get the funding, and that it becomes an important part of each single study that this critical appraisal of the results is included. So the reality at the moment is very often there's a lack of time. Everybody thinks a PhD has to be finished in 3 years. There's the lack of funding. People like to pay you for the main results, but not necessarily to play you around with the data and see, oh, what would have happened if it was like this and this. This is something we have to change at the attitude. And it's at the step of the individual study, but it will be to the benefit of the risk assessors. So I just want to give you one impressive example because, I mean, the prospective cohort studies always are mentioned as our flagship design in epidemiology. And we like to say, oh, we have a study sample that is representative for our target population, because we're always working with samples. I mean, yes, in the Nordic countries, some people may say that Denmark is in reality a big cohort study because you have these many registers that you can link with each other, but it's not covering all the research questions. Lifestyle habits are not necessarily registered. So you're always working with samples. So this is still an interesting example from Denmark, because what we did is we checked whether the people who were invited and decided to participate in the very large diet, cancer, and health study, which is part of the pan-European EPIC study, which I think is very famous. It runs for 30 years, and it has delivered most of our scientific insight into nutrition and cancer. And what you can do in Denmark is actually the people saying, oh, I don't want to participate in the study, you can still follow them up. So what we did is we looked at the mortality of the people who were invited and decided to participate, compared to mortality in the people who were invited but decided not to participate. And this is what is shown in the, oh, there is a laser point, but I have to be direct to the microphone, right? Maybe it looks like, no, not really. Okay, you can see the curve yourself. So what the figure shows is really this mortality ratio between the two groups. So it's the mortality rate in the participants divided by the mortality rate in the non-participants. So if there was no effect, you would end up with a line at the 1 here. But you can see it's not at the 1, it's decreased. So in fact, at the recruitment, the mortality, the first 2 years after the recruitment, the mortality in the participants is 4 to 6 times lower than in the non-participants, or you can say in the non-participants 4 to 6 times higher than the non-participants. And what surprised me is that over the whole follow-up period of 15 years that we had at the time of when we were doing this analysis, the mortality in the non-participants was twice as high as the mortality in the participants. So it was not just the health status at enrollment that apparently had an impact of whether people decided to participate in the study or not. It seems to be a healthy lifestyle, healthy attitude, or whether people go in the study or not. And if you look specifically at the alcohol-related mortality, you could see even a 4-fold difference and not just a 2-fold difference. And then you can imagine who were the people who were missing in these cohorts. So you probably never get a sample that is representative for the target population. But what you hope to get as an epidemiologist is a sample where the exposure-outcome relationship is the same in your sample as it is in the target population. But you have to prove it. And for this, you have to question your data over and over again. You cannot just assume everything is perfect because I'm doing a prospective cohort study. I want to go more in detail of what you can do if you make an effort to see how much did bias, confounding, and error affect my results. At an example where everybody also appears to have an opinion, it's the question of whether the use of mobile phones is increasing your risk of developing a specific type of brain tumor, glioma. And here we had an IARC monograph in 2011 that was actually classifying mobile phone use or radio frequency electromagnetic fields, that's the exposure agent really, as possibly carcinogenic to humans. And before I go into the bias discussion, first, one of the difficulties that we had, because apparently the 2 different study designs that were used to address the question came up with different conclusions. There were 2 cohort studies at the time, one again in Denmark, because you could include register-based the entire Danish population, and a study looked at the early subscribers of a mobile phone, compared them with the later subscribers of mobile phone, which is surely far away from an ideal exposure assessment, but gives you some indication, and you can see here that there's not much to see. And the same was later confirmed by the UK Million Women study, which is a big well, 1 million women, to be precise, cohort study in the UK, which also had a few mobile phone questions included. And here you could see that the mobile phone users of more than 10 years, for instance, did not have a higher glioma risk than the others. And we just updated these results last year, and still no indication. The biggest cohort case control study, on the other hand, that was done on the same topic, the interphone study, which did have the advantage that instead of having only a crude exposure assessment, you could ask people about all the details of their mobile phone use. That sounds quite impressive, but if I would ask you the question now, please give me the month and year when you started to use your mobile phone at least once a week. Please, all the 10,000 participants in the study could answer this question. Huh? Now don't tell me you cannot answer this question. Everybody could. Or everybody did say something. Huh? That's the reality of epidemiology. Huh? You're very often living with self-reported data, and we know this has some uncertainty. So this is a study, 16 centers, 13 countries, and this is the result that we found. And I would like you to keep the shape of this curve in your mind, because we are coming back to it. So this is the result we found, and this is really the lifetime duration of mobile phone use that was estimated based on this questionnaire data. First, you see a little bit of a surprising finding, because it appears to be that some mobile phone use actually protects you from getting a brain tumor. But in the highest decile, so the very heavy users had this statistically significant 40% increased risk of glioma. And that was, at the end, the result that was driving the classification of the IARC. And already looking at this shape of the curve tells you have to do some investigation into the bias and error of this study, because, I mean, even with all the probably also sometimes a little bit emotional discussion about this finding for the heavy users, I mean, this reduced risk in the low users cannot be true. I mean, there's absolutely no biological plausibility how holding a mobile phone to your head should protect you from getting a brain tumor. So something has happened in a study that was creating this result, and it needed an investigation. But of course, when we had finished interphone, there was no time to do this critical appraisal. But we did at least validation studies, and this is very important, and this data now has become very important. But I want to summarize quickly what all the problems are. First of all, I mean, you're asking people about the mobile phone use. This is only a proxy for the radio frequency exposure. And why it's a proxy is what you can see how this is now very old technology. Only the people of my age here probably remember it. It was called GSM technology. And this had an output power of 2 watts if you had a very bad connection to your mobile phone base station. And the output power was going down to 0.003 watt if you had a very good connection to a mobile phone base station. So this is 660 times difference. So theoretically, a person who only uses the mobile phone under perfect conditions could use the mobile phone for 11 hours, having the same radio frequency exposure than a person using it for 1 minute under very bad conditions. And that's, of course, something you cannot capture by a questionnaire. So we first had to ask the question, is the amount of mobile phone use really a good proxy for the radio frequency exposure? And yes, it was. But it was for the reason because the mobile phone operators at the time underestimated how popular mobile phones would become in a very short time. So there were not enough base stations for all the people who wanted to use the phone. So you were never connected to your nearest base station, but you were connected to a base station far away. And almost half of all the calls were at a maximum output power because you did not have a good connection to the mobile phone base station. This is bad for people because they had higher exposure, but it was good for the epidemiologists because our amount of phone use proxy was indeed a good quality indicator for the RF exposure. Whether this still works under 5G, we can't tell you. You would have to repeat this kind of study. But then we looked at how can people recall their mobile phone use, and we were able to get traffic records from the mobile phone operators and compare at least the contemporary use of mobile phones with what people reported 6 months later. And you can look at this scatter plot, and this is even a logarithmic scale. So this cloud is, we were talking about an ICC of 0.6 this morning or so. Well, don't ask me what the ICC is, but the kappa was extremely low. Generally, people underestimated the number of calls they were doing, but they overestimated the duration of calls, on average by 42%. But what you can see is that less than half of the subjects were between the range of reporting the actual use correctly within the bounds of giving at least half the number of calls they did, or twice the number of calls they did. So you see it's a very large variation, introducing random error into the study. But there was also, surprisingly, a systematic reporting error, namely that the people who didn't use their mobile phone used very often, they underestimated their use even, and the people who used it very frequently, they overestimated their use. So you see that the very lowest percentile of users reported only like less than half of their total duration correctly, and it was more than 4 times the actual amount of use that was reported by the heavy users. And this kind of tendency or this type of systematic reporting area, this inflates the range of exposure, and interestingly, that even when the error structure is the same between the cases and controls in this case, and epidemiologists usually like to say this is a non-differential error that always leads to an underestimation of the association. This is one of the exceptions where you have a non-differential error that can actually even inflate an association. Problem number 4, we found more inaccurate reporting in the cases than in the controls. So this was increasing differential error. And finally, and this is probably the explanation why we found this inverse association in the intermediate categories, we also used a non-responder questionnaire, another nice instrument to actually assess study quality, and we found that those who filled in the non-responder questionnaire, that there were more non-users in the controls than in the participating controls. This means that mobile phone use in the controls was overestimated, and this leads then, of course, to the inverse association with the cases. So we found at least an explanation for the finding. And this is the important thing, because a way to increase for your findings the likelihood of whether the effect is causal is to eliminate other explanations. I mean, if you don't find evidence for bias and for confounding, that makes, of course, the finding of your study stronger, because it is true that probably you can never directly show in an epidemiological study whether there's a causal relationship. But you can make other interpretations more unlikely, and that strengthens the causality. So epidemiology is a major instrument for a health risk assessment. So now what do you do in a situation where you have all these competing biases? So we identified 5 different types of bias. 2 of them would lead to an underestimation of the association. 1 would lead to an inflation of the association. 1 would lead to creating a spurious positive effect, and 1 creates a spurious protective effect. Well, welcome to the world of epidemiologists. Okay, that means we went further. We tried to do some new studies, because at the end of the day now we squeezed out everything that we could from the existing material. We started actually to compare the findings from the case control study with the incidence rates of brain tumors. Because with the mobile phones, we have an advantage because, well, say it a little bit in an exaggerated way, in the mid-1980s, nobody was using a mobile phone because they didn't exist. In 2010, everybody was using a mobile phone. So you have an exposure where the exposure prevalence was going from 0% to 100% in only 20 years. So if there's an effect, this should be visible in the incidence rates. And this is what we did. We looked at the incidence rates in the Nordic countries and compared them to different risk scenarios where the hypothetical risk scenarios where mobile phones would cause an increase in the glioma risk. And we now have actually updated these results in 2022, and we can say that even the interphone finding of a 40% risk increase in heavy users has become very unlikely by observing that in the respective age groups where the risk should become visible for the first time, which is the middle-aged men mainly, there has been no increase in the incidence of glioma in the Nordic countries. But then almost a miracle happened, because we found a funding agency who gave us money to go deeper into this bias assessment in the original Interphone study. Fantastic. And this was ANSES in France. Congratulations. By the way, another institution, I've seen the Bundesamt für Strahlenschutz here. That's also an institution who sometimes likes to support methodological work. Thank you to them as well. And we went back to the original validation studies, and we found another error that we have overlooked the first time we actually looked at the result. And this is, you remember this effect of the underestimation of the use in the low users and the overestimation by the heavy users. And the mean error was the same between the cases and the controls. But we found that the variance of the error was higher in the cases than in the controls. And by this, again, introducing a differential bias. And now what we did is that we made a simulated data set of no association between mobile phone use and glioma, simulating the Interphone data set, and we applied the quantitative outcome of the error that we detected in these validation studies to this simulated data set. And what we found is this red curve here. And now I want you to stress your memory and think back of the figure that I showed you on the slide before, the findings of the Interphone results. And if your memory is correct, then you will see, well, that looks very familiar. So what I wanted to show you here is that when you make an attempt and when you let scientists collect additional information, when you give them the resources and we give them the time to evaluate study quality, you can go a step further. Don't wait until the step of the health risk assessment. You have to do this critical appraisal at the time of the individual studies. This is an example where, at least I think, we found more evidence that the association that we've seen in the case control study is caused by bias and confounding. But we also have examples at the agency where by this exercise we can rule out bias and confounding. And this strengthens then by saying, look, what we found is perhaps a really causal association. So finally, some emerging challenges, because unfortunately the world is not getting easier, the world is getting more difficult. First of all, I mean, it looks like we have identified the major cancer risk factors. So maybe the risk factors, the remaining risk factors, we still cannot explain 50% of the cancer burden. Means that we even need more precision in the exposure assessment for identifying these risk factors. Later, we will have a talk on pesticides by my dear colleague Pierre, and this is a field where that is really challenging for the epidemiologists, because we are sometimes comparing low-exposed people with even lower-exposed people, but everybody has some kind of background exposure, and this makes it very difficult to detect a signal. We want to look at study interaction, effect modifications, scene environment interactions. Everything needs not only large sample sizes, everything needs that we keep the errors under control. But you also have to be aware not every error in the exposure assessment is causing the same magnitude of problem in the risk estimation. Well, in the conduct of studies, we also have to overcome two new barriers. One is that apparently, at least in Europe and other high-income countries, there seems to be a decreasing motivation to participate in studies. I remember when I started epidemiology, we were saying when we had 75, 80% participation rate in controls, oh, we have a not very convincing participation rate. Now we get 50% and we say, oh, we have this amazing, almost stunning participation rate in our controls. That's very unfortunate. And also you have a feeling that you know, with the social media and people talking about all topics, that sometimes people now fill in a questionnaire with a certain expectation how they should answer your question. So maybe the questionnaire instruments, they had their time. And, I see I'm at the end of my time. Nevertheless, try to stop me. We have We had so many requests in the first session about give us access to the raw data. I mean, when I moved from Germany to Denmark, I really felt, I mean, from the constraints we had already by data protection in Germany at the time, I really felt suddenly like a free-range chicken now, and look at all the possibilities. But instead, the time turned all the Germans into free-range chicken. They turned the Danes into confined chicken in the egg house, because now we have the GDPR. And surely the intention was certainly not to damage the science, but it is damaging the science. Because now sometimes even between collaborators, we cannot exchange the raw data anymore. So how can we exchange it even with third parties? This is a miracle. When GDPR was coming, as scientists, we were already skeptical, and they told us, well, try it out, you will see it's not so bad. Now we can say we tried it out. Yes, it is bad. So please do something. And we have external factors increasing administrative workload. Sometimes I'm surprised what are the demands on observational studies from ethics. And also we have too few funding frameworks, as I already said, that include proper piloting of studies and that allow this critical appraisal of the findings. And now I really read very quickly my conclusions here. Yes, epidemiological studies should be an important part of health risk assessment because this is studying the agent in humans, and humans are doing all sorts of things unlike animals, and this is only what you can capture in epidemiological studies. But a critical appraisal of bias error confounding is important, not at the level of health risk assessment, but you have to start at the level of the individual studies. Thank you for your attention.